Hello, and welcome to the Alabama Public Health Training Network. I'm Elena Kidd, Program Manager with the UAB School of Public Health. Thank you for joining us for today's program. For some, it's long from over, the long-term symptoms of COVID-19. We would like to thank our co-sponsors for today's program, the Alabama Regional Center for Infection Prevention and Control, the Deep South Center for Occupational Health and Safety, and the Region 4 Public Health Training Center. You can learn more about their programs and the centers as a whole at their websites listed on your screen. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings and webinars and podcasts, request training assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email arcipc@uab.edu with any questions. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access that material. Continuing education credits have been approved for nurses and social workers by the Deep South Center for Occupational Health and Safety for today's program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and complete the Alabama Nursing and Social Work CEU request form on the ARC-IPC webpage. You'll be redirected to this form after you complete the evaluation. The evaluation form will be sent electronically to all registered participants following the program. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. While content may continue to be relevant, CEU units for this program will expire on September 3rd, 2023. If you have any questions or any issues, please email arcipc@uab.edu. And finally, it is my pleasure to introduce our speaker today. Dr. Stella Aslebekian is a senior scientist in genetic epidemiology at 23andMe and an adjunct professor of epidemiology at the Universities of Alabama at Birmingham and Kentucky. She earned her undergraduate honors degree from Stanford, followed by training at Harvard School of Public Health and Brown University. Throughout her research career, she has focused on the nature and nurture question. In other words, how the genes and environment interact to determine disease risk. She has investigated this question in diverse populations using complementary approaches. Dr. Aslebekian's work has been funded by the National Institutes of Health and the American Heart Association. Currently, she works on integrating the large-scale nature and nurture data available at 23andMe to improve models of disease in human populations. So without further ado, it is my pleasure to turn things over to Dr. Aslebekian.
Thank you so much for the introduction, Elena. And while I have worked on those questions of nature and nurture for quite some time, about 3 years ago, I've also quite unexpectedly become a long COVID epidemiologist. And if you've been to any of my previous long COVID talks, some of the materials that I will show today may be a review. But do not worry, because literally in each section of my talk today, there will be updates. There will be updates on treatment, on understanding of long COVID, and on how that connects to what we know about other chronic sequelae of acute infections, much like SARS-CoV-2. So we'll start with a really basic question, which has a surprisingly complicated answer. What exactly is long COVID? And in literature and in society, it goes by quite a few different names. You may know it as long-haul COVID, and that's a word that's meant to evoke the connotation of long-haul trucking, something that's really an endurance event. Post-acute COVID, right, that one is self-explanatory, and of course, if it's not acute, it's chronic. And there are many synonyms, but what they all have in common is that we have COVID-19 symptoms that persist for days, months, or even years in some cases after that initial infection. And well, there's that term long, right? How long do we define long COVID to be? And this is where there's also some disagreement about the definitions. The World Health Organization states that symptoms must be persistent for more than 3 months, and our Centers for Disease Control have a different definition that's actually capturing a lot more patient experiences, and their symptoms must be persistent for 4 or more weeks. Now, what kind of symptoms are we talking about? And this is where I'm presenting data from our own 23andMe LongCovid study. We were in a very unique position to be able to look at this cohort really from the beginning of the pandemic, and I will be heavily drawing on my experience leading that study when I give this presentation today and answer your questions. So what are those symptoms, right? Well, by far the most common one is brain fog. And even that is kind of a nebulous concept, but I think you understand what I mean when I say brain fog. So it's that sense that cognitively not everything is quite there, that you're not quite functioning at your cognitive prime. Very related to that, but distinct, is the sense of fatigue. So that is tiredness. And of course that, as I said, goes hand in hand with brain fog. The third most common symptom is shortness of breath, which of course, given the etiology and pathophysiology of acute COVID, makes a lot of sense and can be quite a disconcerting phenomenon. Now, we are seeing some of the symptoms that are typically associated with acute COVID, like, for example, loss of taste or loss of the sense of smell or smelling things that aren't there. All of those can also be persistent and can be part of that broader long COVID picture. You also see things that are a little bit less specific, like body aches, headaches, some neuropsychiatric symptoms like anxiety, and so on. All of them are summarized here on this slide, and you will see the slide again. What's interesting is that even in May of 2023, there is no consistent definition of long COVID. Different entities use different approaches. As I showed you, there's disagreement for how long the symptoms should be persisting, what symptoms would even count as specifically long COVID symptoms, and so on. So what we do have, and that may be quite relevant to those in the clinical fields, is an ICD-10 code. And even that code wasn't available until more than a year since the beginning of the initial long COVID patient reports. We do have that code now, and it's UO 9.9, and is defined as post-COVID-19 condition unspecified. And previously we had a different code because, of course, clinicians had to code all these symptoms as something. So they just said, well, it is a sequelae of different infectious diseases, and we'll just use that more generic code for that. And you can see that pretty much now, or at least as of January of 2022, most people are using that UO 9.9 code. So if you're working in the space of medical records, that is the one place where we actually do have somewhat of a definition of long COVID, or at least a code for it. The problem with that ICD-10 based definition is that, of course, it's only capturing the experiences of long COVID patients who actually came and saw a clinician. So if somebody's long COVID symptoms were pretty mild, they probably didn't go see the doctor or their nurse practitioner. If they didn't have access to healthcare, they also probably didn't go and seek that kind of healthcare provider support. And of course, I'll say more on the stigma that's sometimes associated with long COVID, and that's another factor that can be impacting whom this definition is actually capturing in medical records. So long COVID has an interesting history. I can tell you as an epidemiologist that it's pretty rare to encounter a new disease, and it's even rarer to encounter a new chronic disease. There are a few other unique things about long COVID. We have evidence that it's probably the first time that patient communities came together on social media and defined that phenotype almost by themselves. And it was patient groups who actually created those terms, whether long COVID or long haul COVID, and that association with long haul trucking was quite intentional. The point is, it's been a new disease. And this is an excerpt from an editorial by Dr. Anthony Fauci. And of course, this was not his first new disease. He was also at the vanguard of combating the AIDS epidemic in this country and in the world. And he's talking about just how rare and unusual it is to have a truly new condition. And of course, not only did we see it with AIDS, we also saw it with COVID, and we also saw it with long COVID. Now, almost always at these talks, I get a question, well, do you think there'll be other ones? Almost certainly, and I can speak more to that if that's of interest. And of course, defining acute COVID was not that hard to do because epidemiologists were able to do the field work to trace it back to where it came from and actually identify the pathogen that's causing acute COVID. And that pathogen is SARS-CoV-2. And you can test for it, and you know what it is, and you know what it looks like genetically and molecularly. We do not have that luxury for long COVID. We actually don't have a diagnostic test that can tell you for sure you have long COVID. All we have are symptoms. And unlike signs, symptoms are subjective. Very often they're self-reported. They're also highly heterogeneous. You see that they range from some very nebulous conditions like brain fog to something very specific like the loss of the sense of smell. And those symptoms also overlap with other conditions. And certainly anxiety is one that comes to mind. So long COVID is a disease that's really, really hard to define because when you look at this symptom chart, you can probably find all kinds of other reasons for just about any of these symptoms. And unfortunately, because there is no objective diagnostic test, there is no biochemical marker or anything like that, historically, long COVID had gotten dismissed a little bit as a condition that patients are just defining in their own heads rather than a true biochemical and medical condition. And we have a lot of evidence that that's a really wrong perspective. And listening to those patient voices became critically important for us to really understand what's going on. Prior to May of 2020, so prior to that early point in the pandemic 3 years ago, it was believed that most people would recover from COVID quite quickly and not have those long-term effects. And just think about something like the flu. That was the main paradigm at that time. But that's not what people were actually experiencing. So a lot of patients turned to social media, groups like Body Politic. And Body Politic later morphed into patient-led research for COVID-19, and that's still active today. And it was in May of 2020, so just a couple of months after the beginning of the pandemic itself, there was a survey of a few hundred patients, and those patients reported their actual experiences that were quite at odds with what the medical community was thinking at the time. But that survey really gave us a first look into what was going on with long COVID. And it was very much a citizen science project, so it didn't have the gravitas of big academic institutions, and nevertheless, it taught us a lot. Now, the gravitas came a little bit later. A very respected professor of infectious disease at a British medical school wrote an op-ed for the British Medical Journal in which he talked about his own experience. And of course, being a professor of infectious diseases, this is not something he was expecting at all. He thought it would be just like the flu, a few painful days, and then the symptoms would go away. But his symptoms at that time had been persisting for 7 weeks. And you can see that he describes it rather dramatically as a roller coaster of bad health, emotions, and exhaustion. Again, quite consistent with other patient experiences. So what else did the survey teach us? The survey eventually gained a lot of traction, so much so that the director of the National Institutes of Health featured it in his blog just a few months later. And it talked a lot about the stigma that patients encountered when they were trying to talk to their healthcare provider about long COVID. They felt like they weren't believed. A lot of times the healthcare providers were overwhelmed with treating acute COVID cases. Remember, this is still quite early in the pandemic. They felt some internal conflict because they felt that they were taking away resources from acute COVID. And there was both internal and external pressure on those patients that was quite unfortunate. And yet, ultimately, it was patient advocacy that was a driving force that led scientists to study it more and generate enough evidence to support some policy changes. So about a year into the pandemic, long COVID was designated a disability under the American with Disabilities Act, so that gives it legal protections. And the numbers are not trivial. We have a pretty good estimate that about 2.5% of the US working population may be dealing with long COVID. And partly in response to that, in August of 2022, the United States, again, through the National Institutes of Health, set up a plan to research long COVID and hopefully understand it better and come up with new treatments. And that was called the Recovery Initiative, and it was a $1 billion initiative. It is represented here in the South through 3 sites in Birmingham, Mobile, and New Orleans. And this is led by the UAB School of Medicine. They will be recruiting about 900 adults who are COVID survivors and following them up over 4 years to see what their long COVID trajectories would be like and what works and what doesn't work. But you can see that before we got to that point where we were designating billions of dollars for long COVID research, there were protests, there were patient initiatives, there were citizen science surveys. So it's quite a remarkable story of a new disease coming into the scene, and really it were the patients who led the way to define it. This is a really interesting time to be giving this talk because literally next week, the public health emergency is poised to expire. This is the public health emergency for acute COVID. So that means the Federal Department of Health and Human Services will no longer consider COVID-19 as a public health emergency. Now, of course, we know people are still getting COVID-19. It's far from over, but it's especially far from over for people who are experiencing those debilitating long COVID symptoms. And this year's estimates show them to be about 65 million strong worldwide. So now that we've defined it, let's talk a little bit about who is more likely to experience those symptoms. And this is, again, where I'll be drawing on my own work with the 23andMe COVID study. So it all began with the acute COVID study, which we started in April of 2020. So if you remember, the pandemic really reached US shores in early 2020, and the lockdown started happening in March. But by April, we were already collecting data on COVID. And the way we collected data, and this is what's shown in those maps, was by targeting states that had acute outbreaks, so that we were able to really capture a lot of the early cases. And that's important, because then we were able to follow them up from the very beginning of the pandemic and see whether or not they developed long COVID. That initial study gave us quite a few responses because we have a large customer database. And we had more than 1 million responses from our customers. And they are also our research participants. And so through that work, we identified genetic markers of COVID-19 risk itself, so who was genetically more likely to get COVID-19 and who was genetically more likely to experience some of those symptoms. And all the participants provide informed consent, and we have an institutional review board that reviews all of our studies. So this was all done quite rigorously, and then we were able to follow up on those initial successes by studying also long COVID. So we wanted to deploy additional surveys to better understand the long-term experience of patients with COVID-19. And we got about 100,000 respondents. So of course, that's a pretty astronomical number. I just told you that the Recovery Initiative is recruiting 900 in just the Deep South region. So we were able to capture a really broad cross-section of the US population. And what we found is that long COVID was fairly common, and at least among our respondents, almost half had some sort of symptom lasting for a month or longer. And when you look at other studies, of course, we want to look at the entire body of evidence and not just our study. You see that those estimates can be really variable, and that depends on the composition of the cohort. What's important to remember about our cohort is that we had a lot of early cases. And a lot of those early cases were not as mild as the cases later on in the pandemic. So it's not unusual for them to get also longer persisting symptoms. So what this graph shows me is that even at the 12 months mark, people were still experiencing all the symptoms that are showing here, whether it's cough or loss of taste or brain fog or difficulty sleeping. We do see that the more time passed since their initial infection, the more they were likely to recover. So time certainly helped, but it didn't help everybody. So you don't have 100% symptom resolution, even for something like cough, even at the 12 months mark, and that is pretty consistent with other studies. And there is a real effect of the initial experience on the likelihood of long COVID. So generally speaking, the more severe the initial clinical course was, the more likely those patients were to continue experiencing those persistent symptoms. And again, those estimates can be quite variable depending on the cohort, but a pretty reasonable one suggests that more than half of all hospitalized cases developed long COVID, about 20% of non-hospitalized cases, and among those who were previously vaccinated, it was a smaller number, it was only about 11%. And what's interesting about the 23andMe cohort is that we started collecting data before the vaccines were available. So one of the questions we were able to look at was whether the vaccine would have any effect on long COVID, and I will show you that evidence later in the talk. What we do now know that from many studies, for as long as we've been collecting data on long COVID, we see evidence of persistence. And at this point, it's certainly beyond 2 years. And I wouldn't be surprised if we're seeing studies coming out now or in a few months from now showing persistence for 3 years. Long COVID has been mentioned on a few thousands of US death certificates. And there's some interesting epidemiology here. Women are twice as likely to get long COVID, but men are more likely to die from long COVID, or at least to have it listed as a cause of death on their death certificate. And it certainly follows this epidemic curve of peaks and troughs, and the biggest peak of long COVID deaths is behind us, hopefully. It happened in February of 2022. So again, we're talking about probably the effect of those early cases. And we do know that, just like with many other outcomes, we see disparities in access to care and in risk. What we do know from the 23andMe study that those racial and ethnic disparities are not because of genetic factors. They're more because of structural factors and different lived experiences of people in different communities. So what we also know is that time helps, and among those who have had COVID, the percentage who are currently suffering from long COVID is decreasing. It's not decreasing dramatically, but it is a hopeful trend that we hope continues. So again, what makes somebody more or less likely to develop long COVID? I already talked a little bit about the severity of the initial infection, right? So the more severe the initial infection, the more likely somebody is to get long COVID. So we know that early in the pandemic, we saw more severe cases, and that's why probably those early cases are more likely to convert to long COVID. In the 23andMe study, because we did not rely on medical records or ICD-10 codes, we really captured patients across the spectrum of COVID experiences. And we certainly saw a dramatically increased risk of long COVID associated with hospitalization, so tenfold to be more specific. I already mentioned that women, most of whom have the XX chromosome set, were twice as likely to get long COVID. And then prior conditions, and this is another nice feature of the 23andMe cohort, we were able to capture those conditions before the pandemic even started. So we know that if somebody had cardiovascular disease or diabetes or autoimmune diseases or even certain mental health diagnoses prior to the pandemic, they were more likely to develop long COVID, and we can talk a little bit about why that is. I teased the vaccine results a little bit. I told you that we were uniquely positioned to study the effects of vaccine, not on preventing COVID, because those effects are quite well established, and not on safety, but what exactly happens with vaccines and long COVID. Well, we know that vaccines usually make the clinical course of acute COVID more mild, and that in itself helps prevent long COVID. But we shouldn't think of vaccines as something that can treat long COVID. So in fact, the majority of our participants, about 50%, told us that they got vaccinated and nothing happened to their symptoms. They didn't get better, they didn't get worse. And then about a quarter of our cohort told us that their symptoms improved upon receiving the vaccine. And then there was a small subsection that was about 10-11% that actually reported a worsening of long COVID symptoms following vaccination. They were in the minority, but it is still an interesting experience, and we don't have a lot of insight into why this could be happening. But what we are sure about is that vaccination is a great preventive tool. It's not a cure. What we found in the 23andMe study was quite consistent with what others had found, but we still don't understand a lot, and we're continuing the study to learn more about the role of comorbidities, genetics, and other factors in long COVID pathogenesis. Now, we have been able to learn a little bit about long COVID, but what do we do about it? And this is where the news perhaps becomes a little bit alarming. You see headlines from 2023 essentially postulating that we don't have an effective treatment. And that's fairly accurate. And sometimes some of the proposed treatments are actually causing harm. And this is what we may be seeing with the exercise trials. You might be thinking, that's really odd. How can exercise be causing harm? But if you're coming from the chronic fatigue world and you're familiar with that condition, you know that sometimes exercise can be harmful, and that seems to be what we're also seeing with long COVID, at least some of its manifestations. A lot of different treatments have been tested, and of course, the problem with long COVID is before you can even diagnose it, you need some kind of a test, right, which doesn't exist right now. So how do you know who actually needs those treatments? How do you know which treatments may be better for which person? And usually to make that call, clinicians just look at the symptoms. So a lot of the existing symptoms are, the existing treatments are aimed at treating the symptoms. A lot of the work that we've done, both at 23andMe and in collaboration with others, really did well in understanding the pathophysiology of long COVID, which is, of course, challenging when you have a new disease, so you have to generate this body of evidence very quickly. But still, there's quite a dearth of treatments that can really do something about long COVID. Now, this slide is quite busy, but to summarize it, it shows you different ways in which long COVID could be affecting health. So it could be immune dysregulation, right? So you have infections, perhaps the pathogen remains in the body for longer than the over-the-counter tests can show us. Or perhaps the immune system is activated in an inappropriate way that's more reminiscent of autoimmune disease. So this is this hypothesis of autoimmunity and immune priming. So you have the pathogen that comes and goes, but the immune system is still reacting to something that's not there. There have been some interesting hypotheses about the microbiome. So those are all the bacteria that live in our gut and other places on the human body. And there's some really interesting evidence that was not generated by our team, but that shows potential relationships between dysbiosis in the gut and long COVID symptoms. There could be a role for blood clotting and endothelial abnormalities. So you could have blood clotting, particularly in the really small vessels, and causing dysfunction. And then there are some neurological symptoms that could also be a part of this whole long COVID story. When you think about something like anxiety and fatigue, those are more neurobiological symptoms. I showed you a chart that had, I think, about 15 to 20 symptoms, but in literature overall, there's been more than 200 symptoms. And again, I keep repeating this great challenge of long COVID work. We don't have a test for it. And when you test long COVID patients using standard diagnostic tools, very commonly everything comes back as normal. There are certain tests in development, but none of them are currently being used in the clinic, despite some of the more interesting ideas. So here's a picture of what I think is a Dutch Shepherd, who is a COVID detection dog. And there have been some interesting ideas for using dogs to sniff out both acute and long COVID. But again, this is all highly experimental stuff. This problem of clearly sick people showing up normal on standard diagnostic tests is not new to long COVID. This is something that we do see with ME or chronic fatigue syndrome, and those conditions are bundled together. There's some really interesting new studies that are using essentially artificial intelligence to better understand long COVID. So some of them have been able to cluster those 200 symptoms into themes, if you will. So the cardiorenal manifestation of long COVID, which is quite serious and can lead to heart failure, the respiratory, the musculoskeletal, and the digestive manifestations of long COVID. So most likely long COVID is not just one disease, right? It's very heterogeneous in how patients experience it. And because it's so heterogeneous, it's really hard to treat because, again, you need to establish, well, what kind of long COVID does this person have before recruiting them into a clinical trial? And I already mentioned, but I'll say it again, that historically and to this day, treatment has been symptom-focused. So this is a list of treatments that had at least some evidence of success. Paxlovid is something we talk about with acute COVID quite a bit. That's a proven treatment. SSRIs, right, so antidepressants, they've also been investigated and certainly can be helpful for some of the symptoms that long COVID patients experience. I already mentioned the controversy around exercise. And so the flip side of that is something called pacing or cognitive pacing. So essentially, it means that a lot of times people with long COVID or chronic fatigue syndrome do not have a lot of energy, so they have to pace themselves throughout the day. So they have to really plan their energy expenditures and allow for sufficient rest to recover, and that's really critical to their well-being. We can also treat potential microbiome dysfunction with probiotics. We can treat immune dysfunction with IV immunoglobulin, low-dose naltrexone, just lots of different treatments have been tested. None of them are definitive, and most of them remain in the realm of symptoms. So this is interesting because I wrote these slides a few weeks ago, and at that point, the belief in the medical community was that the risk of long COVID after repeated infections would be increased, regardless of vaccination status. But of course, literally last week, there's another study that showed the opposite. So we're still really figuring out, well, what is happening with variants and repeated infections? So in other words, if you have the Omicron variant COVID, is it more or less likely to cause long COVID? All we know is that we have mixed evidence on both of those questions, and most likely if a variant causes a milder disease course, it's less likely to become long COVID, and vice versa. So I've been talking a little bit about chronic fatigue syndrome, but that's not the only analogy here. We've seen this before. We've seen situations when we have an initial stress due to some infection that then leads to chronic symptoms. And a really compelling story was published in Science last year And they talked about EBV, or the virus that causes mono, associated with a 32-fold increase of the risk of multiple sclerosis down the line. Now, I already mentioned that we're not sure if it's really immune or autoimmune. In other words, well, is the EBV just hanging out in the blood in some really small amount, and the immune system is overreacting because it sees it there? Or is the virus gone and it's just purely an autoimmune reaction? That remains an open question for scientists. But we've certainly seen that before. We've seen that in, as I already said, multiple sclerosis, chronic fatigue syndrome, and more controversial is the diagnosis of chronic Lyme disease, which, again, there's a lot of mixed evidence around that, but clearly it does sometimes lead to chronic symptoms. There are a couple of books that I would recommend that are here on the slide, and the one on the left in particular is called The Puzzle Solver. Ronald Davis is a professor at Stanford, and his son developed chronic fatigue syndrome, and a very, very severe one, and so there's now an initiative to study it. But again, because this is one of those conditions when you don't have objective tests, and it's even called chronic fatigue, it's so easy to say, well, you're just tired. Well, I'm going to show you some pictures of patients with chronic fatigue syndrome that will illustrate the severity of something like that. And we're seeing something very similar with long COVID. What we do see is just a lot of overlap between those two worlds, the world of chronic fatigue syndrome and the world of long COVID. And right now, the chronic fatigue syndrome community is very excited because finally, because of long COVID, their concerns are being taken more seriously, and there's a lot more investment in research for these conditions. So this is one of those patients. So his name is Whitney Defoe, and he's the son of that Stanford professor that I mentioned. On the left is his picture before he got sick, and on the right is a more recent picture, and he's been suffering from chronic fatigue syndrome for several years now. It's very difficult for him to get out of bed or to feed himself. You can see that he's connected to multiple machines, and he's got a feeding tube installed. And in general, his quality of life is extremely low. This is a disabled individual who is nevertheless a patient advocate and is using whatever energy he does have to motivate others to understand and treat this disease. So the National Institutes of Health have been investing in this condition as well, and now we know that whatever lessons we're learning from long COVID are likely to translate to this condition as well, and vice versa. This is actually my last slide, and after this I'll be ready to take questions. And if you take away one thing from my talk today, is that patient experiences are valid in this long COVID space, and they are to be taken seriously. This is a disease that we don't know a whole lot about, and I'll be here to update you when we do know more. But for now, I think patients are really the best resource we have to understand this condition that's unfolding in real time in front of us. This condition is real. Those patients are sick. In some cases, they're very sick. And it's hard to treat because we don't have a lot of science yet to get us to that point. So until we do, listen to your patients. Thank you.
All right, and we did have one question come in, and please go ahead and send your questions in. Have you experienced reports of intolerance of meat, beef, chicken, and pork since suffering from long COVID, or have you seen that in any sort of the studies that you have done?
That's a really interesting question. I have not seen that, but what we do see with COVID is that it can alter somebody's sense of taste and smell. And I can absolutely see how that leads to aversions or cravings. So I would say I haven't seen it personally, but I'm not surprised.
Okay. And then another question, and I know that you may not have had this population in your studies, but in the literature and whatever other research is going out there, do children also experience symptoms of long COVID, and are their symptoms any different from adults?
That's a great question. So we certainly don't have children in our study, but there's some evidence that children can experience long COVID. I think that evidence is not as extensive as what we have for adults, but it's certainly something that can happen in young people, and children have some other conditions that can be COVID related. So it's probably fair to say that it's a little bit different in children, but it's there, it exists.
And so what is kind of the future direction of the research that you're going to be doing with 23andMe? Where are they going from here, from everything that they have learned, and what's kind of next?
Well, we're a genetics company, so we are looking at genetic determinants of long COVID, and we're doing this both on our own and in collaboration with other scientists. And there are many other interesting questions, right? So in addition to genetics, why is it that people with 2X chromosomes, mostly women, why is it that they're at a greater risk for long COVID? Why is it that certain comorbidities are more likely to trigger long COVID? So one theory that's been kicked around in literature is that those pre-existing conditions essentially prime the immune system to react inappropriately and to continue mounting this response even when acute COVID is over. And there is some interesting evidence there. NIH did a study of allergies, and with allergies what we see is that people who suffer from allergies have this immune response, right, usually to something in the environment. It's spring right now. I'm sure many people who are listening to this know exactly what I'm talking about. And so what we know is that people who are likely to experience allergies are actually less likely to get COVID. Now, it's a very modest decrease in risk, so please do not think, oh, I have allergies, I'm good. That's not how it works. But then, if those people do get COVID, so initially they're protected a little bit, right? But if they do get COVID, their COVID is more likely to translate into long COVID. Because we think this is somebody with an immune system that already freaks out every time it sees something different, right? So maybe it's pollen, maybe it's COVID. So maybe that immune system is in overdrive, and that overdrive protects you a little bit at first, but then that overdrive comes back and causes those persistent symptoms, which is, of course, not a great thing. So what is the role of all those pre-existing conditions? I think there's a lot of interesting work to be done there.
Thank you. And we do have a phone call all the way from Minnesota. So I'm going to go ahead and
please
ask their question. Caller, are you there?
Hi, Minnesota.
All right. We will work on getting them back. So we had another question come in. Have you seen a change in cardiac functions, specifically increasing resting heart rate post-COVID?
Most certainly. This is something that has been reported in the literature. And when I was talking about those symptom clusters, one of those clusters is called the cardiorenal cluster. And that's the one, so it's a very distinct form of long COVID where we do see changes in heart rate. We do see all kinds of actually cardiovascular sequelae. And as I mentioned, this is something you want to take quite seriously because those are likely to have long-term complications, even as severe as heart failure. So yes, the answer is yes.
And then I think we have another caller who is trying to call in again, so we'll give them a few minutes to try to reconnect with us. But in the meantime, is there typically any other long-term diseases that result from other infections, like how does it compare to like Lyme disease or other viruses like the flu or SARS? Are we seeing something similar for COVID as those other?
I'm hesitant to draw parallels to flu and SARS. Of course, SARS would be an interesting one because the COVID pathogen is called SARS-CoV-2, right? It's from that same family of coronaviruses. But we don't have really clear evidence connecting the long-term sequelae for those. What I will say is that we certainly have this paradigm of acute infection causing long-term problems, right? So Whitney Defoe's chronic fatigue syndrome is believed to be caused by an acute infection that he contracted in his travels. And I already mentioned the science paper on multiple sclerosis where we have the virus that normally causes mono can also cause multiple sclerosis down the line. So it's something we see quite a bit in literature. But it's not yet clear. And I'm personally very intrigued by this connection between chronic fatigue syndrome and long COVID because the symptoms are so highly overlapping. and patient experiences seem so similar epidemiologically. For example, a lot of the same risk factors are true for chronic fatigue syndrome patients, that we think that perhaps there's some underlying biology there that we can harness and be able to treat both of those conditions. So when you're asking me about future directions, this is one that I think I'm more excited about, both for the long COVID patient community, but also for the chronic fatigue syndrome community, because that's been a community of patients that's been knocking at researchers' doors for quite some time and did not get too much attention until long COVID became a phenomenon.
So I think we have our caller back from Minnesota, so we're going to try to patch them through.
Long COVID became a phenomenon. I think we have our caller back from Minnesota, so we're going to try to patch through.
So we're having a little trouble hearing you. Could you start repeat your question from the start again?
Okay, I hadn't started.
Okay.
I'm sorry that I hung up. I thought they had connected me to the wrong thing because it took a while.
No,
and
that's
I had
okay.
hung up before you had a chance to ask the question.
No,
but my
thanks.
question is, with your patients, have you tried using additional vitamins and checking their vitamin D levels and stuff? Like for vitamin D, increasing vitamin C and zinc?
Yeah. So, of course, I'm not a physician, and this was an epidemiologic study, so it was not an intervention study. We didn't do it in our study, but I know that there have been efforts like the one you're describing, and certainly calling from Minnesota, you're well aware that most Americans are vitamin D deficient. So supplementation with vitamin D is quite likely to be effective in relieving at least some of the symptoms. For example, some of the mood symptoms or some of the fatigue symptoms. It's probably not going to be enough for the more severe cases, but I do think it's a promising direction of research. Again, I cannot speak to experience in literature that I'm deeply familiar with, but I think those are things that are unlikely to do harm and are probably worth trying. I'll take a look in literature as well, and I'd be happy to update you if there's any way for us to get that feedback, because now I'm really interested in that question.
Yes. The other question I was saying, I know you were saying that the healthcare providers should listen to their patients. So how do you, patients been talking to their doctors and have been dismissed. So how do you keep talking to a physician to let them say that they don't, it's just all in your head? Because they may have had mild COVID, maybe not have really tested for COVID, but could have had COVID in the past. So how do you deal with that?
Let me just recap your question, because we had a little bit of connection issues. So you pointed out that I said we should listen to the patients, but then you said, well, how can you actually make providers listen to patients, right, in the absence of objective markers or tests? So in other words, well, what if a patient shows up and their provider does say it's all in your head and maybe it's too mild? Was that the question? Like, how do we convince the providers that this is real?
Yeah, it's happening, especially because I'm an African American, and so I really have, and I'm a retired nurse. And as a nurse, I have to advocate for myself, even when doctors know I'm a nurse, to treat me less than. So I'm just for the population as a whole, and for minorities in particular. How do we get providers when you talk and they still dismiss you?
That's right.
At this day and age, they should be aware that they need to be doing full histories on clients, but they don't.
You're absolutely right. Thank you for sharing your experience. And we certainly do see that patients who come from minority communities, their concerns are even more likely to be dismissed. So your lived experience is completely aligned with what we also see in literature. And it's completely valid, of course. Part of the reason why I do these talks in the community is to raise awareness and to convince providers that this is real, and those people are very sick and their experiences are to be taken seriously. Awareness, of course, will be really critical. I think the more recent initiatives from the NIH will help too, because now we have federal funding going to long COVID related questions, and they will be producing studies that are quite officially documenting those lived experiences. So it's not just from one patient here and one patient there, but this is data that are collected in a more systematic way. And I think NIH is in a good place that they're finally taking all of this seriously. Now, that's not always been the case, and unfortunately, it might take a while for those things to really trickle down. It's hard for me to give you very practical advice. Sometimes what I personally do is actually bring articles to the providers' offices when I'm interested in a specific diagnostic tool or a specific treatment, and I ask their opinion on that, usually coming prepared. And of course, being a nurse, you have that background to be able to read those articles and share them with the doctor. Sometimes, it's like, well, if they don't listen to you, maybe they'll listen to somebody who published on this topic. And of course, I wish they'd just listen to you, but maybe that could be one practical suggestion with providers.
Okay, I appreciate that.
Thank you.
All right, thank you.
Thank you for calling.
We have had several more questions come in. So in your study, have you seen people with COVID-induced sciatic neuropathy? A few weeks ago, I spoke with someone who had COVID in 2020 and has been experiencing sciatica for 3 years.
We've certainly, I cannot speak specifically for sciatic neuropathy, but we've certainly seen neuropsychiatric symptoms. So again, it's one of those things, it's probably under that list of 200 symptoms. So it's not something that came out in our study, but it's certainly something that's biologically and etiologically plausible.
And so we've had, again, a couple more questions that have come in. I know we talked about this even on our way here, but do you think it will be recommended for all to get a yearly COVID vaccine, just like the flu vaccine?
I think that's exactly what's going to happen. And I don't know yet it'll be the same vaccine. Probably it'll be still different vaccines. But I really think we're heading in that direction, and that is my opinion. It's not totally evidence-based, so I want to be clear about that, but I do think that's the direction we're going in. And of course, the virus itself keeps mutating, right, just like the flu virus, so those annual boosters will be necessary to address the more recent strains.
And I know you talked about a list of 200 symptoms, but has hearing loss been reported as a symptom of long COVID?
Yes. Okay. I'm so glad you brought it up, because this is actually something that another participant reported that their father had hearing loss. And we started looking into that because that was an interesting symptom that we'd never heard before. And we found cases in medical literature of exactly that happening, particularly among older individuals who are probably already experiencing some hearing loss. That one we've seen.
Okay. And I know that you have talked about brain fog and that being one of the more prominent symptoms of long COVID. But what sort of treatments have been kind of put out there to address the brain fog? Because I know that some people have experienced much worse brain fog, since their second case of COVID. So
yeah, well, so I think this is where the strategy of cognitive pacing is really helpful. You can look it up in literature. It's quite well described. So essentially budgeting your energy and knowing when you're experiencing more or less brain fog and scheduling your demanding activities for those times. This is a management strategy, not a treatment strategy. So I want to be quite upfront about that. Brain fog is also something I would love to investigate with regards to SSRIs, right? So antidepressants can be a potential strategy here. But again, I would need to see the evidence, whether or not that's actually been investigated specifically for brain fog. But this is one hypothesis that I'm comfortable putting forth. And if I wanted to be funny and cheeky, I would say coffee, but I don't think that's a funny topic, so I won't.
Thank you. And can you please talk a little bit about POTS and the symptoms of POTS related to long COVID?
Yeah, so this is postural orthostatic tachycardia syndrome. I hope I got this right without any notes. And essentially what happens is when a person stands up or changes their position somehow, their heart rate accelerates, right? So they experience this episode of tachycardia. I know we already had a question about heart rate changes, so this is one way in which this could happen. And this is a condition that is also very real and quite unexplained. And this is a condition we've been seeing in medical literature, not without its own controversy prior to COVID. And we are certainly seeing it in the context of long COVID. We also saw it with chronic fatigue, right? So those conditions just kind of cluster together. So POTS, some of them potentially mast cell activation syndromes, long COVID, chronic fatigue. So those are all conditions that we've been unfortunately ignoring because it's so hard to biochemically characterize or address them. But it is something that we are seeing in the context of long COVID as well. And so that could be also related to the cardiorenal cluster.
Okay. Well, I think I'm just going to give people a couple more minutes, but I think that is all the questions that have come in through live chat and through email and on the phone. Perfect. Thank you so much for being here.
Thank you for the opportunity. Thank you for letting me be here and present a 2023 update on the state of long COVID epidemiology. And I think there's a lot more we can learn, and I hope to be a part of that.
Well, again, this concludes our program today. I want to say a big thank you for Dr. Azbekian for being here, and thank you for watching. As a reminder, CEU units for this program will only be awarded by the Deep South Center for Occupational Health and Safety. After completing the evaluation that will be sent to you electronically to all registered participants, you will be redirected to the Alabama Nursing and Social Work CEU request form. If you experience any issues or have any questions about the CEU process, please email arcipc@uab.edu. That's arcipc@uab.edu. Thank you so much and have a great day.